Welcome, everyone. Thank you for joining us today. My name is Dr. Amanda McIntyre, and I am from the Arthur Labatt Family School of Nursing at Western University, and I am the RNAO Nursing Research Interest Group Chair. And this webinar series is really initiated to share and promote nursing research and scholarship across our broad nursing community. And in these sessions, we feature speakers who bring their innovative research across academic and community settings and address how their work can inform transformative changes in practice, education, and/or policy. So our speaker will present for about 30-40 minutes, and this will be followed by some time to take questions. We encourage you to ask questions at the end or leave your questions or comments in the chat so that our speaker can address them. And just a reminder that today's session will be recorded. I would like to do a land acknowledgement before I introduce our speaker. I'd like to acknowledge that at Western University, we learn upon the traditional lands of the Anishinaabe, Haudenosaunee, Lenape, and the Chinookutan nations. So I have the absolute pleasure of welcoming today's speaker, Dr. Maureen Leyser, and she will further introduce herself and her new credentials, and she's going to deliver a presentation today called The Development, Refinement, Implementation, and Impact of a Nurse-Led Health Coaching Intervention for Heart Failure Self-Management, Self-Care Management. So Dr. Leyser, I will turn it over to you.
Okay, great. So thank you for the invite. It is a pleasure for me to speak on behalf of this group. Just to give you a little background history, I have been nursing for over 32 years. First 10 years has been a registered nurse in critical care. The last 20 plus years has been a nurse practitioner. I hold my license in primary healthcare nurse practitioner, but also have my acute care nurse practitioner and master's. And really my whole background, I grew up in a very small rural area, really been affected with some social health inequities, just being in a rural area of a population of 400 in southwestern Ontario, and really saw the challenges that my parents and my family endured trying to seek medical care more remotely when you're living there. And so it impacted me to go into nursing and really wanting to have more of a group effect and an impact with my clinical experience as well as my personal experience on healthcare service delivery. And so for that reason, I embarked on the PhD journey for the past 6 years and was able to develop self-care management intervention for basically chronic disease, but it was specific for heart failure for my dissertation. And I was pleased to defend successfully this past October. And today is an honor to share with you my results of a 2-phase trial. And then I'm welcome to take any questions. So without further ado, if you'd like to advance the slides. This is my committee. They were very committed over the last several years. And most of you will be quite familiar with the first two people, who was the director of School of Nursing, and Dr. Marilyn Ford-Gilbo is very much invested in women violence and her research there. Dr. Robert McKelvey is a well-known cardiologist globally, but he also sits as the chair for the Heart Failure Advisory Board in Canada. And Dr. Sonia Riker is a family physician, specialty in diabetes in family health teams in southwestern Ontario, particularly London. Next slide. So with 22 years of experience as a primary healthcare nurse practitioner working with patients and their families who live in heart failure, I come to this research with a working knowledge of the challenges and facilitators related to self-care management and heart failure, and a belief in the commitment that there is a need for primary healthcare approaches in this domain. Now, heart failure is a major global health issue affecting over 26 million people. And in Canada, more than 750,000 people are living with heart failure, and over 100,000 people are newly diagnosed each year. There is no cure for heart failure. Next slide. Despite medical advances and patient education, there continues to be a high hospital readmission rate and prolonged hospital length of stay, the average being 7 days. That may lead to challenges with effective heart failure treatment and management. Next slide. Now, currently, effective nurse-led interventions have been developed to support self-care among people living with chronic disease, including diabetes, COPD, and pain. Now, self-care practices may help stabilize symptoms, slow the progression of the disorder, and improve the patient's quality of life. But health coaching holds promise in self-care management with people living with chronic disease. Now, health coaching is different from motivational interviewing. Health coaching is not counseling. It involves multiple encounters with patients and families and uses patients' goals to guide the conversation as a foundation for tailored, patient-centered care. Whereas motivational interviewing may be 1 to 2 sessions of specific education to help patients resolve ambivalence and make a commitment to behavior change. Next slide. Healthcare providers often fail to inquire about or address the patient's ability to carry out these self-care activities important to well-being because it often relates to their lack of resources, including time or support. They also often fail to consider the caregiver's contribution or perspective in care planning. So the primary healthcare approach, rooted in primary healthcare principles, fosters active patient and family partnership as partners in their health. Now, the primary healthcare approaches have demonstrated promise in improving self-care, but interventions to assess heart failure patients are limited and were mostly done in the acute care setting. Next slide. Now, the central problem, there is no nurse-led health coaching intervention shown to be effective to assist patients to engage in heart failure symptom management with self-care activities within a primary healthcare setting. Next slide. To address this gap in the literature, the primary aims of this research are to, 1, develop and refine a nurse-led health coaching self-care management intervention for people living with heart failure. And that was my phase 1 of the study. Phase 2 is to examine the feasibility and the initial efficacy of a nurse-led health coaching self-care management intervention for people living with heart failure and their caregivers within a primary healthcare setting. So by engaging with this research, it is my hope that findings will inform clinical practice, education, research, and policy. I will now provide you an overview of phase 1 of the study, followed by the description of the intervention and theoretical framework, and then provide you an overview of phase 2 of the study. Next slide. For recruitment, the Family Medical Clinic Administrator sent an invite to all the clinic nurses from the 2 primary healthcare sites as an opportunity to participate. And if the nurses were interested, they would contact me through email. A total of 19 nurses were invited to participate and 10 nurses volunteered, 8 RPNs and 2 NPs. A focus group meeting was arranged in person at one of the family medical clinics, while the other site video conference in to refine and further develop the nurse-led health coaching intervention and tool. Nurses identified then the educational needs to employ this intervention for phase 2. Now, the research questions posed in phase 1 are listed on the slide. And they are: what are the challenges or gaps in providing care for heart failure patients within the community and family medical clinic? 2, what are the nurses' experiences and perspective of health coaching and adopting a health coaching tool in their practice with their heart failure patients? 3, what do nurses identify as the essential features of the intervention? Are they captured in this tool? And if not, what changes can be made to improve this tool? And lastly, what are the opportunities to further develop the nurse's role in order to improve heart failure care for patients and their caregiver? Next slide. The theoretical framework that has been selected is the situation-specific theory of heart failure self-care. It is relevant to my heart failure patient population. Now, the strength of this theory is that it's pragmatic approach and underpins the importance of people making real life decisions that are meaningful and familiar to them. Now, the key elements involve natural decision making process that influences actions on managing their chronic disease. Now, moreover, another theory is important was the caregiver contribution to heart failure self-care. These two theories have a positive influence on each other and together will help in the development of the intervention components related to heart failure self-care management. Next slide. So this is the nurse-led health coaching intervention comprised of 5 elements. Number 1, it was complex, meaning that it had multiple components or interactions to inform many of the factors, such as who is delivering or receiving the intervention, the number of outcomes, the degree of flexibility or tailoring of the intervention. And it was also aimed for various levels, such as individuals, community, or specific patient population. Number 2, it was nurse informed and led. It supports nurses by having structure to ask standardized questions to guide the nurse's self-care conversation with a health equity lens with the patient and caregiver. It also identified any challenges and barriers to engage in heart failure self-care activities with the aim of achieving practical change in everyday nursing practice to improve care for heart failure patients and caregivers. Number 3, it is person-centered, tailored approach. The patient developed a tailored action plan and goals with the nurse's support. And number 4 and 5 is the education tools and self-care activities. It featured a traffic-like format, adjusted diuretic dosing activity to support the patients and caregivers to learn about how to monitor and manage their heart failure symptoms, and to promote self-care and achieve heart failure stability, and to improve quality of life. Now, let me show you a few inserts of this guidebook that we used for the intervention. Next slide. This page is the most important page for the nurse. So when they got a booklet, the first page is this page that the nurse will be guided through questions. The rest of the booklet is for the patient to use as a heart failure self-care management tool. So the first page on the left-hand side is a nurse's guide to cue them on health coaching principles and approaches. It really guides them with some key questions to start their patient interaction in the office with them and to be quite consistent. The right side is where they will ask questions. Now, these questions are very guided to managing heart failure congestion. And so we looked at it, and it's embedded with the situation-specific heart failure theory. We looked at the situation, the problem, and the environment, and we asked key questions. Basically, for the situation, their ability to manage their congestion. Are they currently working or unemployed? So looking at that financial lens and their time constraints. Do they have drug coverage? Do they have difficulty buying healthy food or paying for housing? And do they have a working scales? So just like diabetes, if you do not have a glucometer, it's very difficult to manage your diabetes. For heart failure, everything is about their scales, their weight, and how you would monitor any weight adjustments, such as weight gain. And the rule of thumb is if you gain 3 pounds in a day, it is not related to fat in your diet. It is related to fluid buildup. And if you gain 5 pounds over a week gradually, again, that's fluid, and that needs to be adjusted with the aid of diuretics. We also look at the problem. Are the ability to weigh themselves daily? Can they get on the scales safely? So you're looking at some mobility issues. Can they see the numbers on the scale? And do they have any symptoms of depression or sleep disturbances that affect them from observing their weight by other medical conditions? And then the environment. Do they live rural? Do they live alone? Are they isolated? Do they have any transportation issues? By the nurse going through some of these pointed questions, they might be able to identify any gaps in their current plan of them successfully managing their chronic disease, specifically heart failure. And together they might be able to provide a solution. For example, if they have difficulty seeing the numbers on the scales, do they need a talking scales? And maybe that's all the nurse needs to do is help connect them with the community to access them a talking scales. If they have problems getting on the scales, maybe it's a referral for physio, muscle strengthening, so they're able to get on safely, so they're not afraid to weigh themselves. Small things like that make a big impact for the patient's management. And it all starts with engaging the nurse, engaging these conversations with the patient and their caregiver. Next slide. So this slide is it's an educational tool for the patient to use. When I talked about the traffic light, it's put on the fridge, and it's very simple. If they're in the green, they're good to go. They're maintaining their ideal weight that the doctor or nurse practitioner has set for them. And the nurse can help walk them through to guide them if they're above. The caution light is when I said they're 3 pounds over their target weight in one day or 5 pounds in a week. And if they're having more difficulty breathing, or if they see extra swelling on their feet or ankles, or their pants are getting a little tight compared to a couple of days ago. And that's when they need to think of, do I need to adjust my water pill for a day or two to see if I can get that more under control. And then red is they need to stop. They're very short of breath. They have dizziness, chest pain, very difficult to breathe. This is where, yes, I need to reach out to my family health team. I need to reach out to my nurse at the clinic, or I need to go to the emergency department. So this keeps them on track on a daily perspective. Next slide. So within this booklet, it has a calendar like this all the way for a whole year. They can put their date in. They can check off every day what their weight is and what zone they're in, and if they had to take an extra water pill. So the extra water pill would be guided by the nurse practitioner or the physician feeling that the patient and or the caregiver is very capable of self-adjusting their water pill for a few days if they're out of target. And then when they see their family physician, nurse, or nurse practitioner, they will bring this booklet with them, and it has a guide of how they're doing over a period of a week or a month. And they get a great line of sight of how they've been managing. So again, the nurse in the clinic would help coach them how to use this type of sliding scale and calendar. Next slide. This is the picture of where the nurse practitioner or the physician would set them up for a sliding scale. And it's basically they give them a target weight of what their dry weight would be, and they would fill out the chart of what their weight should be and if they need to take an extra pill. And at the bottom, it says, after 3 days, if your weight is not back down to normal, you need to call the office or go to the emerge if your symptoms aren't improving. And again, that's kind of the safety net feature of seeking more help and getting reassessed in a timely manner. So that is the educational tool and activity to go with the health coaching self-care management intervention. Next slide. So we took this tool into phase 1. We asked them for feedback, basically the feasibility of implementing this, what their thoughts were about this tool, and how we could refine it to make sure it was successful. And this is what they came up with. As I said, we had 8 RPNs and 2 NPs that weighed in on this tool from 2 different family health clinics. And the barriers were, they said, the challenges will be, it's a busy clinic. Patients' social circumstances often can make it challenging, of how would be best to manage them because they're quite complex and patients are often very overwhelmed. But the opportunities is this is not part of their usual care that they do, and that there's very few self-care management heart failure tools to self-adjust, and that this was a great opportunity. It also promoted nurses to work to their full scope of practice. And with this, they said we would need some education just to really know the nuances and the up-to-date information about management of heart failure, treatment of heart failure, and of course, the causes of heart failure. The strengths of this tool was it was very simple, easy to follow. It was appropriate literacy level. It was structured questions for identifying health inequities, goals, and action plan for the patient's involvement. And the threat was they had to prioritize learning opportunities for medical residents. So the big takeaway, and which was quite surprising to me, what I was unaware of, is, within these family medical clinics, they have a lot of residents and medical students. And often they are seeing the patient and limits the nurse's time to spend that one-on-one time to really understand the patient's challenges or their gaps in their health care. And so for that reason, they said, that was a threat. But this research opportunity actually gave them that golden hour with the patients. That was their time so that they can start building that relationship back again. Also, their threat was there's limited nurses' roles and work within a primary clinic, meaning the strong message was they're often task oriented. They take blood pressures, they take blood, they do a lot of tasks, but they don't often do a lot of that therapeutic nursing relationship. And so being in a busy clinic, it is limited to that. Next slide. So this led with the refinement of that tool. There was very little that we had to do except for some cosmetic things, rearranging a few pages and actually taking out one page and putting it as a fridge magnet, which was a big success. So the patient actually had something on the fridge every day that would remind them, as well as their caregiver. So we made those changes and we went into phase 2. And for phase 2, we did a very similar enrollment. We asked the administrator to send out an invite to all the clinic nurses, including RPNs, RNs, and Ps, to 3 sites. 2 were from the original one. And there was an opportunity to participate, and 4 nurses came forward. Now, you have to recall that this was just when we were starting to get back in person with the COVID pandemic. So there was a lot of pandemic fatigue during this time. And so the volunteer rate was lower. but we did get 3 RPNs and 1 RN. The heart failure patients were identified by a clinic roster produced by the EMR with the primary heart failure diagnosis. And the nurses reviewed the patient's list with the physician and or the nurse practitioner to determine eligibility for the study and overall suitability. 44 patients were identified, 32 screen failed, 12 were eligible, and 7 declined for various reasons. And 5 patients remained. There were flyers in the waiting room. And if you're wondering how 32 screen failed, some of them were a one-time heart failure episode related to maybe a rapid heart rate. It was or very incidental, or they had COPD and not heart failure. Or they were going into a nursing home. So there were certain things that they weren't eligible. But the 5 that remained the nurses discussed the study, that there was a pre-screened, and that the caregiver was also given the time for their regular booked appointment and invited them to participate. Consent was obtained for these dyads, and education was provided electronically through a PowerPoint of a 90-minute on heart failure with the management treatment and prognosis for heart failure. At this time, we also reviewed self-care management techniques, heart failure coaching principles. For the site readiness, we arranged a one-on-one in-person visit with the nurse participants to review all the study protocols, the procedures, the clinic visits that would take place over a 3-month period, and the surveys they needed to complete at the end of the study. And the surveys that they completed was a pre-post intervention, looking at self-care confidence and quality of life. And we did a total of 5 visits for every patient over a period of 3 months. This included the initial visit, 1 month and 3 month in person, and then a telephone visit at 2 weeks and 2 months. So there was contact either every 2 to 4 weeks on a regular basis. And at that time, the nurse can review goal setting, action planning based on their concerns that they brought forward, and talked about how to self-manage their heart failure successfully based on their weights and what they were going through at that given time. At the end of the study, we interviewed both the patient and caregivers separately, and then we interviewed the nurses as a group to see what they thought about the feasibility of the study. Next slide. Now, the methodology used in this study was explanatory sequential mixed method study. It was a non-randomized design. It was a quality approach involving interpretive description that was employed when conducting the interviews. This included reflective journaling and field notes. And there was a quantitative portion of the study where, as I said, we did pre-post outcome measures such as self-care management and quality of life through surveys. Next slide. Now, this interpretive description, it's a pragmatic methodology, and it's rooted with phenomenology, and it's widely accepted by researchers in applied health science, particularly in nursing. It is influenced by a number of qualitative traditions, and it fits my research objectives. It is very practical, practice focused, addressing situations sensibly and realistically in a way that is based on practical situations. Next slide. Now, the data analysis for the qualitative It was through understanding the reflective experiences from the interviews by themes and patterns identified that revealed clinical relevance. Next slide. And to ensure scientific quality of the qualitative study, it had to have some rigor, which we had member check the common themes and patterns that were identified. The rigor was also enhanced because our qualitative measures complemented the quantitative measures complemented the qualitative measures. There was credibility because we did develop a good rapport during a 3-month study with the nurse and the patient. It was dependable because there was well-established protocols and we had a structured interview guide. The reflexivity involved the researcher's self-awareness, which I always stayed in tack of my own thoughts and trying not to have any bias within the study. And triangulation. It was both qualitative and quantitative methods. The triangulation is we would constantly compare, integrate, and interpret the results from both arms of the mixed method study. Next slide. So let's get to some of the data results. From the 5 dyads that we had, the patient demographics, they were mostly female. The average age was 75. They all had 3 or more chronic conditions. Their New York Heart Class Association was class 2 out of 4, meaning that they were short of breath with usual activity. So these are still fairly stable patients, which that was kind of what we wanted to start with. The heart failure medications, 100% of them were on 2 out of the 3 guideline medications. Their kidney function was unchanged, and we really wanted to monitor this pre and post because they were self-adjusting their diuretic. We want to make sure that they were not doing any harm to their kidney function, so that was reassuring. And the patients mostly lived alone, and the caregivers had a variety. There was wife, sister, daughter, and friend. So next slide. So the qualitative part. For the nurse focus group, 3 themes came out of it. Rediscovering how to nurse. Nurses voiced the challenges with the current clinic practice to work full scope of practice, often compromising the nurse's ability to use their knowledge and expertise to fully perform their role more fully in a direct patient care in the clinic and not just for heart failure patients. And one of the quotes were, there are days where we struggle. It is more task and not patient focus, but we are trying to move away from that. Obviously, with us being a teaching facility, the residents take priority when it comes to nurses being involved in appointments. So they have that learning opportunity. Number 2, supporting patient agency. Nurses assumed an active role in cultivating person-centered care. The nurse-patient therapeutic relationship further developed, resulting in feelings of professional fulfillment because the nurses could see how health coaching benefited patients' health and wellness. And lastly, relational inquiry. This approach to communication is important because it can help the nurses understand the patient's situation more fully and focus on what was important to them. And one key, I think, captioned that one nurse report, and it's in the middle. They said, I found this tool itself. The booklet was very helpful because seeing your values and your weights right in front of you, especially for the patient specifically, was very motivating for her. In terms of weight loss goals and making sure that her health was in check, it was very rewarding, especially seeing how much the patient enjoyed the outcome and how invested she was. And like the positive progress that she was making and feeling that she was in control of her health, This was very rewarding to see. Next slide. So the three themes that came out for the patient's experiences was one, relational engagement, supporting health promoting practice. The patient spoke about the nurse being more involved in their health needs through the nurse-led health coaching intervention with the focus of a more tailored approach. This fostered a close nurse-patient relationship. Now, this type of relational engagement supported participants to assume an active role in self-care by understanding the why of their disease trajectory and supported the readiness to act on how to related to self-care management through increased certainty and reassurance by the nurse. Number two, the next theme was the traffic light tool, the weight and self-care management. Patients demonstrated being more active in taking on the work of maintaining, monitoring, and managing, such as adjusted diuretic dosing, while seeking support when needed. Patient revealed that through this nurse-led practice, they were able to develop strategies and tailor these strategies to manage and monitor their heart failure in a focused and purposeful manner. And number three, the social support. The role of the caregiver, someone who gets it. It was quite telling that all the patients said that essential elements of support of these caregivers were that they were dependable, compassionate, trustworthy, and positive, in addition to assisting with problem solving. And so one of these quotes that resonated was the first one, relational engagement. She said, I have known her, the nurse, for over 20 years, but this was a different thing. Like, before I would come in and she would take my blood pressure and the doctor would come in and see me and that's it. Now it's a bit more involved. It is a different relationship. I think it's even closer. Now, the next slide is the themes from the caregiver group experiences. Again, three themes came out. One was a relational engagement, the moral encouragement, the emotional support and structure through the nurse consistency and stability. And so through this relational engagement, the importance of consistency and stability was working with the same nurse before and after appointments and building the patient's confidence, leading to improved self-care skills. Number two was the health education and self-care management. That fluid management is the key element to heart failure self-care management, and a factor that caregivers and patients have been made acutely aware of through this health coaching and teaching. The relationship with the nurse was identified as the key element in supporting self-care management. And lastly, caregivers as active partners in self-care management. This study spoke about the importance of being an active participant in care. However, most of them did not live with the patient. If they were, and also they stated in this that the patient got the tool, but the caregiver didn't get that magnet or the tool. And because they didn't live alone, some of them felt that if they also received the same information if they lived remotely, this would have provided them to be more informed when the patient would call them at home. They also had the same reference material to look up to help them guide their loved one a little bit more effectively and consistently. Next slide. So that was a qualitative portion. The quantitative portion was through surveys. It was the self-care and quality of life surveys to be completed by each of them. And again, as you can see, they were guided through well-known established surveys that have high psychometric properties. Next slide. So the next couple of slides will just talk about the quantitative results from these surveys. Heart failure self-care surveys for patients. There was a paired t-test that was performed, and they had 4 subscales from self-care maintenance, monitor, management, and confidence. And they did these surveys before the health coaching intervention, and they repeated these surveys post health coaching after 3 months. And it showed that we did mean and standard deviation, and they calculated to explore trends. Because our number was not very high, all we could do is look at some possible trends. And a score of 70 or higher represents adequate self-care management behaviors. And the only improvements for the patient in self-care management that were significant was in self-care management and self-care monitoring. Next slide. And as you can see, there was significant improvement with the caregivers. So the caregivers also did a pre and post mean score for all self-care scores. And it is showing that the changes in self-care maintenance was significant improvement after this intervention. Next slide. The qualitative results for quality of life. Now, we have one on the patients. Now, you have to know that for patients' quality of life, the higher score means more burden. So post-intervention, the patient's score was lower, indicating a trend for improved quality of life. Whereas the caregiver score had a different calculation, and the higher score showed improvement of mood and happiness. But overall, the caregiver score did not alter much, therefore showing not significant changes, but they did show higher on happiness. Next slide. So we are coming to an end. So I just want to say the limitations of the study. This was a feasibility and study and an impact study. And we employed more of a proof of concept approach. I want to acknowledge that these results from the quantitative measures cannot be generalized to the general population because of the small sample size, and that my sample size is not powered to detect differences between the 2 groups pre and post interventions, but only possible to look at notable trends. However, this sample size for both nurses, patients, and caregivers is appropriate for interpretive description. Next slide. For discussion and clinical implications, health coaching intervention needs to be addressed for the contextual features of the patient's life and care, and needs to be tailored. And the nurse needs to be prepared to address these social determinants of health. We also clearly identified that there is a strong nurse-client relationship that is essential to ensuring that we deliver person-centered care that has the foundational to deliver holistic family-centered care. And lastly, organizational shifts are necessary to support health coaching role in nurses, making sure that they have that allotted time to spend with those patients to engage in these important relationships. Next slide. In regards to the implications for education and policy, relational inquiry as an approach to nursing practice needs to be considered more in the nursing curriculum. It also includes principles of health coaching in the nursing curriculum, because this is so important for chronic disease, which with our aging population is so prevalent. And nurses need to advocate to work to full scope of practice within nursing organizations and other healthcare organizations. And that we need to have policymakers to urge to hold healthcare organizations accountable to delivering good and appropriate time with these patients. Now, the conduct of this research needs to be on a larger, more diverse sample. And this research is transferable to many working patient populations living with chronic disease, such as COPD, diabetes, and stroke. And in diverse settings, such as acute care and community care, needs to be considered. Next slide. Conclusions. Nurses are well educated and skilled, and often their skill set is underutilized, particularly in the primary healthcare setting. And the findings of this study suggest that the nurse-led health coaching is a promising intervention. It is often patient-centered, tailored approach within the primary healthcare setting. It also has a positive trend in relation to increased patient self-care management behavior while improving quality of life. And lastly, relational engagement is a key element of the nurse-led health coaching. And while the nurse can gain confidence in working to their full scope of practice. And that's the end. I'm welcome to take any questions. Or any comments, Michelle?
Hi, so thank you so much, Dr. Leyser, for this. I'm just starting my PhD journey and I'm also doing health coaching. So I'm really this was really exciting and topical for me. I have about, I have like 10 questions, but I'll try to go into some things. And then if anyone else wants to jump in and interrupt me for all my questions, that would be great. So for the nurses that were involved, were any of them certified health coaching? Like what was sort of their qualification to be a health coach?
Yeah, so none of them were certified. We did take an inventory of where their clinical practice was. Many of them worked in medicine, ED, mental health. Their average was 10 years, but we've had as young nurses as 2 years and as high as 30 years. So they felt, we talked about that. We talked about, they said that they kind of do motivational interviewing or health coaching all those years when they're dealing with that, but they have not had formal interventions. Okay. And when I was doing my literature research on many health coaching trials, some people do put their nurse participants or whatever participants in a health coaching program. But because they were nurse-led and we gave them the principles of nursing, we didn't have a structure coaching.
Okay. And then I have another question. It was wonderful. Just going to say that first. So, the program was nurse informed, and I'm wondering what you thought about sort of having a patient informed intervention. So what was sort of your decision making to have it only informed from the clinician side and not from the patient side?
So I would say one of the takeaways was the nurse informed, but with the interviews, it was very much caregiver informed, patient informed, because we did all those qualitative interviews and we took those themes. So, but you're talking about the tool itself, right?
Yeah, at the beginning.
Okay, so the tool itself, the background, which was an interesting question. Before we even got there, I worked on a heart failure floor. And when I was working on just developing the raw data, I had like several renditions of it. And I would take it to some of the nurses on an acute heart failure floor and an educator. And I actually brought it to a couple of heart failure patients saying, you know what, I'm thinking of implementing this tool. Do you think this would be helpful? So that guided me having some input as I was developing this, because this took me a year to develop.
Some informal gathering first. Yeah.
Yes. Yeah. And I've also spent 20 years caring for patients in a heart failure clinic. So I took all that feedback from all the years of handing them pamphlets and what they said worked and didn't work to this point. So I had that kind of clinical experience from them telling me and me really looking at why are they coming back in heart failure? What's not working?
Okay, great. Yeah. I'm also, yeah, I'm trying to figure out like, yeah, what's feasible in a PhD, you know, sort of in that time frame, like what stakeholders to involve.
Yeah.
I'm going to be looking at gestational diabetes. So
Yeah.
sort of that prevention of developing type 2 later on. So if there's any sort of tips that you have for your time frame or research process as a PhD, anything that took longer than you thought, or, you know, things like that.
Yes. So, because you're affiliated with the university, you have to have it ethics through Lawson and the university. But because I also implemented it in a family medical clinic, it had to go through their research committee because they were a teaching family medical clinic. So it just added a little bit more time, and sometimes a couple of months adds up because I had 2 phases. So this took a while because one, it was a new intervention, it was novel, and two, had 2 phases. But that just took a little at a time. I the feedback I did get from my examining board, which would be very helpful, is the people that did screen failed. There was a high number of screen failed. So you look at why was their screen failed? Is it maybe difficult for them to kind of get in? The interesting part is, would you even consider employing this tool through home care and community care instead of a busy clinic? And that was a good perception, because you may not have, you know, as much of a screen failure rate. It's just another area, clinical area, that is very underserviced and maybe not researched enough, and yet needs a lot of support. So when you're looking at gestational diabetes, let alone a clinic, I'm sure there might be home care attached to maybe some of these patients, that might be another avenue you might want to employ, the intervention,
Yeah.
and linking with home care in some rural areas that may not be able to get in, because some of them were, I don't have rides, I don't have transportation, I live alone. So actually having the community nurse learn the tool and employ it and send it to them, I think that might be a good setting to consider.
So were all the interventions done face to face in person?
Yes. So,
Yeah.
but they did
Okay.
have 2 telephone calls. So
Okay.
they were seen initially, and then at 2 weeks was a check-in, with a telephone call. How are you doing? Are you understanding? Are you checking your weight? And then they came back in 2 weeks later, which is at 1 month in person. And then we wanted them to gain some independence, so we stretched it that at 2 months is a phone call. And because they were living with heart failure, they've done some of these things. It wasn't a brand new diagnosis. So we could leave that. And then it was a telephone call at 2 months. And at any time they felt that they were unstable, then of course, as normal, you would tell them to come in. And then there was an in-person at 3 months, which was end of study.
Okay, great. Thanks so much.
You're welcome.
Wowzer, Maureen. Thank you, Michelle, for all the questions. I think it just really highlights the sheer amount of work that you've done, Maureen. And I had the privilege of starting my PhD with Maureen. And I would like to just say to everyone, Maureen, you've had this idea from the beginning. Like you were insistent on seeing this through. And there were so many people, to your point, Michelle, about the amount of work and planning for things and barriers. There were a lot of people who thought maybe the project was just a bit much for a PhD, but I'm so proud of Maureen for, seeing it through and doing this great work, because your vision was there 5, 6, however many years ago that was. So really great. And I feel like this is, I'm really glad you came to speak today to showcase, in a very short period of time, all the work that you've done through the years. So thank you for joining us. It's great to be on the other side now.
Yeah, I just would have to comment that the results that I was most surprised about, because I was so focused on the clinical side, was the nurse relational engagement. That was very fascinating. And so that kind of led a whole different other type of work besides the clinical heart failure work. It's now, I'm really passionate of really ensuring that whatever the nurses do, what, you know, RPNs, RNs, NPs, that they work to their full scope and that the patients can benefit from their expertise that are often not used, and just giving them the right environment to do it. And that's what that will help. So that was a good take home and lessons learned from this project for me as well.
Great. Amazing. Thank you. Well, on behalf of NRIG and all of our members, I want to thank you for coming today. And we invite everyone to come back for our next webinar. We usually have one per month, and in some of the months we have two. So look forward to promotion on the upcoming speakers in 2024. Thank you.
Thank you for having me.